So this is the June 2024 MEC Minute, and at the time of me recording this, it's in the 70s and due to be 95 this afternoon. So I think our topic this month of heat illness is timely. I've given this talk before, but because of our increased ranks, a lot of newer providers within our agencies, I felt it was appropriate to touch on this topic again. And I really want to emphasize a couple things about heat illness that I will do toward the end in terms of exertional heat stroke and how time critical it is that we intervene. So it doesn't matter whether it's an athlete or a firefighter, we need to be aware of exertional heat stroke and how we aggressively manage it. So I'm going to talk about that toward the end. I want to start with just some conversation about thermoregulation. How do our bodies manage heat? Well, heat flows from hot to less hot, so that's why when you touch something hot, it burns your finger because the heat's going from that hotter item to your finger. Heat goes from hot to less hot. That's why if our body is hot and it's outside, it's cool, the heat leaves our body principally by evaporation, but leaves our body, it goes out into the environment. So the key to thermoregulation in our body is to maintain that temperature gradient from inside the body to the outside. Heat is balanced in multiple ways. One is conduction. That's contact between two bodies. That's that example I gave about touching something hot with your finger. Heat goes from something hot to something cold. Convection is heat loss or gain via air or water movement. That's why we use fans to cool. That's why we get in cold water to cool. So that's convection. There's radiation of heat, and that's heat transfer that's independent of air movement. A good example is you have a dark piece of clothing on and you go out in the sun. That dark clothing becomes warmer. It warms your body. Radiation and sun exposure is important when you're working outside, particularly if it's not cloudy or you're not under the shade. And then there's evaporation, where liquid changes to vapor, and as part of that process, heat is conducted away from the warmer body. It's what our body does to really regulate when we're under heat stress, and it's very important in a hot and dry environment. It's impaired in a hot, humid environment simply because when it's hot and humid, your skin cannot evaporate sweat as easily. For this to work, you have to be well hydrated, which is why we're encouraging all firefighters during hot days to start hydration in the morning and continue hydration through the day. And the evaporation is our body's usual means of maintaining body temperature, particularly when under heat stress. It's also why you sweat when your fever breaks. Your temperature is 102, your fever breaks, you sweat to get rid of that heat so that your temperature can get back to the normal of 99.6. Heat illness, and that's a broad category. Heat illness is what we're going to use as a term to include all of the items I'm going to discuss next. But heat illness occurs when your body's under heat stress and your body cannot thermoregulate. In other words, the heat gain exceeds your body's ability to lose heat. That heat gain could be because you're in a hot environment. It could be because you're exerting yourself and your muscles through exertion generate heat. It could be because you're exerting yourself and you've got bunker gear on and your body can't get rid of heat. So heat illness is whenever you have heat generation that exceeds your body's ability to lose that heat. Exertional heat illness is where you have increased heat generation due to physical exertion, and your body is unable to shed the heat. And for firefighters and for athletes, this is the circumstance where they tend to develop heat illness. They're doing something that's heavy duty work, and their muscles are generating extra heat, and the firefighter or athlete is not able to shed that heat, is not able to get rid of the heat that the body is generating. Hence, their core temperature goes up. It's not a continuum. It's not like you get heat cramps before you have heat syncope, before you have heat exhaustion and heat stroke. You can go from normal to any one of these things without a step in between. Heat exhaustion or heat syncope on one day can be a warning sign or red flag that you're going to have a heat stroke on another day. So if you go outside, work hard, and you feel exhausted, you come inside, hydrate, and after an hour or two, you feel better. And then the next day, you go out and do the same thing. You are at increased risk to develop a heat stroke. So your body has already shown the predisposition to suffering from heat exposure. How about hyperthermia? Hyperthermia is when your body temperature is elevated beyond normal due to failed thermoregulation. The body produces or absorbs more heat than it can dissipate. Um, and when extreme core temperature elevation occurs, it becomes a medical emergency. And when you have that medical emergency, it requires immediate treatment to prevent disability or death. So typically, our normal core temperature is 99.6. If you talk about an oral temperature, it's 98.6. Um, but if you're having under heat stress, your temperature could go up. Typically, heat stroke, which is where you are the most immediate danger. Your core temperature is about 105 and higher. So it's a range, anything higher than 99.6 to anything over 105. There have been reports of 108, 109 body temperature, which is never a good thing. So if you have extreme core temperature elevation, it's a medical emergency, and you have to treat the patient immediately, particularly for exertional heat stroke, which we'll talk about. And I'm talking about you have to do things on scene. You can't wait for a 15-minute transport to the hospital. Let's talk a little bit about heat stress. A lot of times, if you look at talk to the athletes or the athlete trainers and the sports medicine physicians who really become the experts in this, at least in terms of exertional heat stress. They talk about wet bulb temperature. When you're looking at it here as a device, it's actually three different sensors. It senses the temperature just with a regular thermometer. It measures the temperature with what they call a wet bulb thermometer, which is where there's water or a water wick at the base of the thermometer as part of the water probe. And then there's this black knob. The black knob, what it does is it measures the radiant heat. So if you're out in the sun, that black bulb will absorb heat, and all of that goes to generate a wet bulb temperature. It's what athletes or athletic trainers and sports medicine physicians look at. On the right-hand side, wet bulb temperature, if it's under 82 degrees, it's pretty much not a lot of heat stress. You could rehydrate with water or Gatorade. And as you go up, it becomes more and more stress. Typically, when you get over 82 degrees, you start to get into higher risk for exertional heat stress and exertional heat stroke. And then when the wet bulb temperature is over 92, you're at extreme danger. And so the wet bulb temperature is not the same as what the ambient temperature is. So typically when your wet bulb temperature is around 95 and 100% humidity, your body can no longer sweat or lose heat by sweating. So that 95 degrees wet bulb temperature is really the upper limit of when you should be outside. Wet bulb temperature 95 is the same as 95 degrees on 100% humidity. Comparable reading with lower humidity with, let's say, a wet bulb or a temperature of 115 with a humidity of 50% also gives you a wet bulb temperature of about 95 and the same risk of heat stroke. So hyperthermia, who's at risk? Athletes are at risk. We are all well aware of what happens with football players in the summertime with their two-a-days. The coaches and the athletic trainers pay close attention to the ambient heat. Those who work outside, so all the construction workers who work out in the heat, the elderly, extremes of age, elderly and very young, so prepubescent and elderly, just do not have the thermoregulation tools in place that allow them to adapt to heat. The socially disadvantaged can be at risk because they cannot find a cool place to escape the heat. And those on certain medications. Certain medications block our body's ability to thermoregulate. Who else might be at risk? Well, it's you guys, which is why I want to talk about this now. It's why when we have a working fire, extra trucks are assigned during times of extreme heat because you need to cycle crews in and out quicker in order to reduce their individual heat stress and reduce their risk for heat-related illness. Again, some additional risk factors, poor acclimation, irregular exposure to heat stress. So if you don't spend much time outside and it's now hot outside, you decide to go out and do 4 hours of yard work, that's going to put you under stress. People who have cardiovascular disease or who are just in bad physical shape do not do well in the heat. Sleep deprivation, for some reason, can also increase your risk for heat-related illness. Certain medications, so antihistamines like Benadryl, beta blockers like metoprolol or propranolol, anticholinergics like some of the GI meds, and then diuretics like hydrochlorothiazide or Lasix can increase your risk factors or your risk of developing heat illness in various different ways. The anticholinergics and antihistamines and beta blockers tend to block your body's response. Diuretics tend to dry you out. And then another risk factor is if you just don't hydrate before the event. Again, this is why we're harping on it's hot outside. You start your shift after truck checks. Start hydrating. Take fluids. And additional risk factors again are the elderly, athletes, and firefighters. Prevention of firefighters. What can you do? Acclimation is important. Recently it was pretty cold out. Now it's hot. We didn't have a lot of time to acclimate. Think about frequent cycling of your crews, those extra truck assignments for big events. I know I'm harping on hydration, but it's important. Start with morning report and keep going. Caffeine, I think we all take caffeine in some form, but caffeine we have to recognize can cause dehydration and increase your risk of heat stress and heat-related injuries. We need to organize and mandate rest and hydration. We need to cycle crews in and out. When you're wearing those bunker gear, your body cannot lose heat. You know that better than I do. You might sweat, but the sweat's not really cooling you because it's being soaked up by your gear. Think about how we can actively and passively cool somebody. So active cooling is, we'll talk about it, but it is, ice baths. It's wet, cold towels. It's putting arms and forearms in buckets of water, or it could be misting. Whereas passive cooling is fans, taking off all the gear, sitting in the shade. One question you need to think about, and I think you understand later in the talk, is are you able to ice somebody down at the scene? If somebody develops severe heat-related injury, can you put them in a tarp, fill the tarp with the patient as well as water and ice to cool them down on scene? That's something to think about. It may take more than one igloo ice chest to do this. Assessment and treatment. So, it's like a lot of things we do in medicine. High level of suspicion. Patient's having chest pain. Is it his heart? Maybe it is, maybe it isn't. But you have that high level of suspicion. If it's a hot day and you have a firefighter who doesn't feel well after working at a fire scene, you need to think about, is this provider, is this person suffering from heat stress? One of the most important metrics for you to consider and when you assess a patient are vital signs and mental status. So if you're talking about the heat-related illnesses, typically there is a change in the core temperature. The core temperature is elevated, and the patient may have some change in mental status. They may have had syncope. They may be confused. They may be unconscious, or they may pass out. So really the two biggest parameters to pay attention to is vital signs and mental status. Temperature. So you have a firefighter, you have a patient, and you think they have a heat-related injury. How are you going to check their temperature? Well, we all got used to using the infrared thermometers during COVID. Well, they may be a good screening tool for a patient with upper respiratory symptoms, but they are not a good tool to evaluate somebody's core temperature. When we talk about core temperature, we're talking about either a rectal temperature or an esophageal probe, which is giving you temperature. At the hospital, we have temperature sensing Foleys that we can insert in the bladder, and they will also give us a core temperature. So think about what's on your truck. If you have a firefighter or a patient go down in the heat, maybe it's an athlete who's been out running in the heat, are you able to do a rectal temperature? If you're not able, then you need to talk with your EMS coordinator about getting the equipment you need so that you can, in the privacy of the truck, or in some area that's private, drop the pants and check a rectal temperature. We have to know what the core temperature is. Oral temperatures are not adequate. Axillary temperatures are not adequate, and the infrared thermometers don't come close. So think about how you're going to check the temperatures on these patients. All right, minor types of heat-related illness. There's heat rash, which is kind of like an itchy red raised rash. It could be in the areas where the clothing is. It looks like little lumpy, bumpy, finely sandy-like a rash. It's benign. It's going to get better. You allow the skin to dry, change to dry clothes. Cotton seems to be better than the polyester items for this. And we prevent it by bathing regularly, keeping the skin dry, and thinking about cotton clothing. Sunburn. We all know sunburn. We've had it at one time or another. It's red, painful skin and blistering. So, we can see providers who don't have their boonie hat on. They don't have any hair on their head like me. And now they've got sunburn on the top of their head. How are we going to treat it? Well, if it's first degree, if it just looks red, then we're going to use lotions. If it's blistered, then they need to seek medical care. The best way to treat sunburn, like a lot of these heat illnesses, is prevention. You know, go into the shade, wear protective clothing. If you know you're going to be outside, if you're going to work an event, work a carnival or something, if you're going to be outside, use some type of sunblock or lotion. They talk about SPF greater than 15. I would start with 30 or 45, but the better you can, or better protection you can get, the better you are as a person in avoiding sunburn. Heat cramps. So it's really the least dangerous of heat illness. It's you know, fatigue, sweats, cramps of the arms, leg, maybe some belly cramps. Their body temperature might be elevated. So maybe they've been out, person's been outside working, or an athlete, and their legs are cramping up. They're thinking clearly and normally. There's no confusion. And if you check their temperature, it's mildly elevated. So it's, maybe 100.5, 101. How do we treat these patients? We rest them, we cool them, we get them out of the sun. We cool them either actively with wet cloths and any of the other clothing or wet, cooling items you might have. You can put them in front of a fan, start them on oral fluids, and or you can massage the body parts that hurt, or the patient can massage their own body parts. Typically, these patients, after hydration and rest, can go back to what they're doing. It may take 30 to 60 minutes, but with time, they will get better. If you check their core temperature and it's 100.5, they want to go back to what they were doing. Their temperature needs to be normal before they go back. So recheck the patient, recheck the vital signs. Heat syncope. This is also a mild form of heat illness, and it's secondary to exertion in a hot environment. And the patient feels faint or lightheaded. They may have a transient loss of consciousness. Sometimes they may be orthostatic, so they sweat so much that they lose blood volume, and when they stand up or change positions, they become lightheaded because they're orthostatic. They can have nausea and vomiting. Typically, they have tachycardia. The body's responding to the heat stress, responding to the hypovolemia. And if you check their core temperature, it's elevated, but it's less than 104. If it's over 104 or over 105, it's not heat syncope. It's heat stroke, and you got to do something. You got to act even more aggressively. These patients should be rested and cooled. They should be started on IV fluids. If they have substantial hypotension or orthostasis, it's okay to put a line in and give them some fluids. You need to assess for other potential causes of their syncope. So you need to check a blood sugar. You really should put them on a cardiac monitor, particularly if it's somebody 35 and up. You need to evaluate for an arrhythmia. You need to evaluate for a STEMI. You need to get vital signs. These patients, if they pass out, need to be removed from work. They should not, if it's a firefighter, they should not go back into the building. They should not go back into suppression or what they were doing. They need to be transported and evaluated before they're cleared to return. So if somebody passes out from heat, they don't go back to work. They go to the hospital. Heat exhaustion, it's similar to heat syncope. The cardiovascular system can't maintain adequate circulation. You have decreased circulating volume, you're dehydrated. You can have headache, lightheadedness, nausea. You can have cool, clammy skin, so it's cool, but it's not perfusing well. And their core temperature is elevated, but it's less than 104. It's really very similar to heat syncope. The only difference is you feel lightheaded if you're exhausted, but you're not passing out as you would with syncope. Treatment is very similar to heat syncope. It's rest and cooling, oral fluids. IV fluids may be necessary. That's your call. And they really should have cardiac monitoring until their vital signs stabilize. and they should have a 12 lead. Just like heat syncope, these patients should be removed from work and they need a medical evaluation. So, this heat injury, they can develop renal failure and hyperkalemia and rhabdomyolysis. So it takes a bit of evaluation that needs to be done at the hospital. These patients should not go back to practice, should not go back to the fire ground. They need to be cooled and transported. And they also, when we talk about like temperature again, it's rectal temperature on these patients. Rehab. So you're at a fire scene. What are you going to do? Well, how do you cool down? Well, the first thing you do is, and I'm sure you're aware of this, is you take all the clothing off. So you take off as much clothing as you can. So all the bunker gear comes off, the boots come off, the hood comes off. The patients move to a cool spot, whether it's a cool room or in a vehicle that's got air conditioning, or it's in the shade with fans. You cool things down with cold cloths on the neck and the body. You can put cold water on the face and the scalp. You can immerse the forearms in a bucket of cold water. And you could also provide cold oral fluids if they don't have significant nausea. Medical assessment, really you need to check vital signs frequently. If you're going into rehab, you need to have vital signs. If they're abnormal, they need to normalize before you go back on the fire ground. The patient, depending on severity of their symptoms, may need cardiac monitor to determine rhythm. Blood sugar is appropriate, and they all should get a temp. And you know what kind of temp I'm talking about. So if the patient has minor symptoms, oral temperature, if they close their mouth, is probably adequate. If they have significant symptoms of heat-related injury or illness, you need to go to a private spot and check a core temperature. I know you really don't want to do that on your crew members, but it's in their best interest. Let's talk about heat stroke. So really, when we talk about heat stroke, there are two kinds. There's classic, which is what we think about when you think about the elderly who are in their hot apartment. The ambient temperature outside is 95. Their apartment is 100 because they don't have the windows open and they don't have an air conditioner. These patients tend to be sedentary. They tend to be chronically ill, and they often tend to be on prescription medications. For these patients, the problem is they're absorbing the environmental heat and they're not able to give it off. So the temperature of their home or where they are exceeds the body's ability to shed heat. These patients may be absent or they may not be sweating. They may have dry skin. They tend to be confused. They can even be unconscious. They can have some respiratory alkalosis just because they're breathing fast. And they generally do not have rhabdomyolysis or breakdown of the muscles. Exertional heat stroke is what we think about with firefighters and athletes. It tends to be in people who are active and teenagers and above, but not elderly. It can happen any time of year because this is exertional heat stroke. It's because of excessive heat buildup from strenuous physical activity. These patients are generally healthy. They generally are not on any medications, although they may have some performance-enhancing drugs that they use, whether it's testosterone or something else. And for these patients, it's a problem with exertion or excessive heat production, um, which overwhelms their heat loss mechanisms. These patients tend to be sweating. They typically have some alteration in their level of consciousness. They can be confused. They could be unconscious. They could have a seizure. These patients tend to have a metabolic acidosis. It's not something you're going to identify in the field, but we might use it to discriminate in the emergency department, one type from the other. And these patients typically have frequent rhabdomyolysis. So that's, again, muscle breakdown. Myoglobin is released from the muscles, and the myoglobin can clog up the kidneys, causing acute kidney failure. It can also cause hyperkalemia. A couple summers ago, I had a soccer referee who'd been outside reffing all day for weekend soccer, and he came in with a core temperature 102, and he was in acute rhabdo with a creatinine 3 times higher than normal. He improved with hydration, temperature control, and he left the hospital normal in a couple of days. So it's a continuum, but you have to think about it. Classic heat stroke, it's severe hyperthermia with organ dysfunction and damage. These patients typically can have kidney problems, liver problems, rhabdomyolysis is not so common. Their core temperature is over 104. They're altered in their level of consciousness. They are dehydrated. The skin can be wet or dry. They tend to be hypotensive and tachycardic, and they may have vomiting and diarrhea. We want to cool them down. So for you in the field, we'll cool them down maybe by getting them out of the building, fan, cool soaks, maybe some cold IV fluids if you have it. You can start IV fluids. They may need a liter or two, but to normalize their blood pressure and pulse rate. But typically, they're not severely dehydrated. They do require cardiac monitoring because they are at risk for bad outcomes, and these patients need to be immediately transported. So let's contrast that with exertional heat syncope or heat stroke. Corey Stringer, some of you may be old enough to remember Corey. He was a offensive tackle at Ohio State. He went off to become a professional football player. He died from exertional heat stroke after he became unresponsive during practice in the summertime. When he got to the hospital, his core temperature was 108 degrees. He died the next day. This was in the early 2000s. There is now a Corey Stringer Foundation, and the focus is on preventing exertional heat stroke in athletes. Our sports medicine physicians and our athletic trainers have become the experts in exertional heat stroke. So we look at them in terms of how they should, or how we should be treating these patients. If you are called to an athletic field and an athlete's down, and the trainer says we have to cool this patient before you move them, they are correct. You need to listen to the trainer and get this patient iced down, and we'll talk about that in a moment. So again, wet bulb temperatures. Wet bulb temperature 95 degrees is the same thing as 95 degrees and 100% humidity, or 115 degrees and 50% humidity. But at a wet bulb temperature of 95 degrees, your body's not able to give off heat via evaporation. So your principal way of losing heat is null and void at wet bulb temperature 95 degrees. You simply can't give off the heat through sweating. So exertional heat stroke, it's severe hyperthermia, 40.5 degrees Celsius or 104.9 rectally, 104.9 degrees Fahrenheit. We just round up to 105, and that's by rectal temperature. And the patient has CNS dysfunction. So like I mentioned earlier, the key items to look at are CNS function, awake and alert versus unresponsive or confused, and rectal temperature. You need to rapidly recognize this. Typically, it's a hot and humid environment. Again, with a wet bulb temperature over 82. Over 82 degrees is when the risk goes up. If you remember that chart I showed early in the game, the 82 degrees was the yellow zone, and it only got worse from there. Not everyone is unconscious. They may still be sweating. So the fact that they're sweating doesn't mean that they could not have exertional heat stroke. And the treatment is immediate whole body cooling. It's been shown that if you immediately start to cool the body on scene before you transport, you can greatly limit the adverse outcomes of the hyperthermia. So these patients are cooled first and transported second. If you have an athlete or a firefighter goes down with exertional heat stroke, your first priority after ABCs is to get them in an ice bath and get their temperature down. And we don't transport them until their temperature's down to about 102, 102.5. So plan on staying on scene. This is why I asked if you had access to ice and cold water on your trucks when you're on the fire ground fighting a big fire. Here's our protocol in terms of heat exposure. This is out of our protocol. It covers a lot of these things. It really doesn't cover a lot of what I'm talking about for this exertional heat stroke. We'll probably make some modifications to really get caught up with the athletic trainers. So you have a patient with exertional heat stroke or stress. What's your means of assessment and treatment? So the patient collapses. It happens during physical activity, firefighter. Athlete, they're either at a game or during training, and it's hot and humid. There's a significant heat stress. Check the responsiveness. If they are unresponsive, ABCs always come first. After you manage ABCs, are they altered or not? So if they are altered, Obtain vital signs and a rectal temperature. For the chart, they say over 40.5. I threw in there 104.9 because most of us think Fahrenheit. And if it's 105, 104.9, 105 and above, you begin whole body cooling, and you cool them until their temperature is down about 101.5. So you stay on scene, and then you transport. So if you look at the right-hand side, you've got some poor volunteer in a tarp, and there's water and ice in that tarp, and everything gets covered and cooled except for the head. You got to keep the head out. You got to keep the face out of the water. But you got to get this body cooled down, and you need to periodically check their rectal temperature before you put them in the truck and transport. That is contrary to a lot of the things we've talked about for critical illness where scene time is important. In this case, it's slow down, cool the patient, transport when their body temperature is improved. Complications for heat cramps, heat syncope, and heat exhaustion. Really, there's no long-standing side effects as long as we cool them down and provide fluids and reassess them and verify that there's no other underlying conditions like hypoglycemia or cardiac arrhythmia or STEMI, non-STEMI. Heat stroke, there is risk for long-standing end organ damage. It could be neuro, it could be renal. If you have rhabdo, which is muscle breakdown, you can develop significant renal disease, but the heat itself can cause renal complications. And the risk of complications from exertional heat stroke can be reduced via quick cooling. If we cool the patient fast, the risk of neurological complications, the ultimate of which is brain death, is vastly reduced. So if the patient goes down, they're hyperthermic, you do a rectal temperature to find that they're hyperthermic, you put them in a tarp, you get ice on them, you cool them down with water and ice. So in summary, heat illness can be mild to severe. Hydration is important in terms of preventing symptoms. Hydrate, hydrate, hydrate. At a wet bulb temperature of 95 degrees, which again is 95 degrees and 100% humidity or some version of that, the body is not able to give off heat. Your evaporative cooling is basically void. Medications and poor physical condition increase risk of illness. Minor heat illness can result in heat stroke the next time, and exertional heat stroke is deadly. You can die from this. Corey Stringer died from it. Unfortunately, he was a great athlete. So if you have an athlete who's outside, or a firefighter, or a construction worker who's outside, and there's significant heat stress, and now they've got altered level consciousness, check that temperature. If it's over 105, start on-scene cooling via whole body ice bath. You've got to get their temperature down to 101.5, 102 before you move the patient, unless you're able to find a way to put them in the ice bath and then put them in the truck and transport them. I think that logistically is difficult, but you're the experts. I'll leave that to you to figure out. But you've got to cool them. You can't wait to get them to the hospital. So that's all I have. Thank you very much. Please hydrate. Please stay cool. If you have any questions, please call me or post it on Basecamp. Thank you.